Thanks. By the Valley Health Regional Collaborative, if any other persons are present are doing the same, you must notify the chairperson at this time. We'll call to order the meeting. And could we do a roll call? John?
Yeah, John Hillman, Board of Health, Leverett. Hello.
Hi. Garrett?
Garrett Simonson, Shutesbury Board of Health.
Tim?
Tim Hilchey, Deerfield Board of Health.
Ryan?
Ryan Paxton, Montague Board of Health.
Am I missing someone? Just Bruce. Okay. So for new business, I'm hoping that we can switch the order, that everybody would be okay with that. We have Kyla here from the Foundations of Local Public Health Services, and she wanted to give us a summary of our survey. Kyla, do you want to go ahead?
Yes, thank you so much, Megan. My name is Kyla Botzian, and I'm a consultant with BME Strategies, and we're working with the Office of Local and Regional Health in the Department of Public Health. With me here today is Katie Roan, who works for the Office of Local and Regional Health, and also Ileana, who is the program coordinator for your shared service arrangement, also with OLRH. So I'm going to share my screen, and we'll go through the preliminary results for your SSA. I think I need permission to share my screen.
Matt, is that something you can do? Matt's still here. Matt is gone. Does anybody know how to do? Oh, host tools. Look at this. Allow parent. I think I just did it. I think you can do it now.
Yes, perfect. Thank you. Okay, so hopefully you guys can see my screen now. I'll jump right in. I already gave my introductions, but we'll go through the preliminary data, go through some of the overarching spending categories for your shared service arrangement, and then hone in on two foundational areas or capabilities that Megan and I determined would be most applicable to talk about for your shared service arrangement. And then we'll talk about the data to action toolkit. So we can't rename ourselves on Zoom, so that's okay. I'll skip this step. And I already introduced myself and the folks with OLRH. So thank you guys all for being here today. The purpose of this presentation is really to provide actionable insights that align with long-term capacity building goals, including identifying areas for increased shared services with an emphasis on enhancing foundational capabilities and meeting phase 1 of the performance standards. And the goal of this presentation is to understand how FPHS preliminary data can guide decisions and support each stage of the FPHS planning and capacity building for phased implementation. So the Foundational Public Health Services, or FPHS framework, was developed by the Public Health Accreditation Board in collaboration with a national network of public health experts and recommended for adoption by Massachusetts in the Blueprint for Public Health Excellence, and it is written into the SAFE 2.0 legislation. So the foundational areas, which are shown in this teal color in the circles, are core public health programs and services that are necessary to keep communities healthy. And then the foundational capabilities, which are shown in the dark or the navy squares, are skills and functions that are needed to support basic public health protections, programs, and services. And throughout this presentation, you'll see the same colors, teal for areas and blue for capabilities, to represent them. And the Massachusetts Department of Public Health's Office of Local and Regional Health is adopting this national framework as envisioned in the blueprint and written in the legislation. And while local public health is not responsible for delivering all of the services in this framework, they are responsible for ensuring that the foundational public health services are available within their communities. So this can be through external partnerships or collaboration with the shared service arrangement staff. And these preliminary summary tables are not intended to be an evaluation in any way, shape, or form of local public health or your shared service arrangement. Rather, they're just tools to support you with understanding the current services and resources and identifying opportunities to share resources and improve service delivery. Hopefully the train going by isn't, you guys can't hear it. So in this guide, we won't have time to review all of the results today, but this table of contents provides an overview of what's available in the presentation, which I will email to Megan after the presentation and she can share with all of you. And we will review parts of the preliminary spending and foundational area and capability data and key takeaways. And we'll do a quick introduction to the tools that will be available in the data to action toolkit, but we won't be able to review the data interpretation guide or the appendix during this meeting, but these are available in the presentation as a resource should you want to look over them after. And the data appendix provides additional data that could be useful in further interpreting the summary slides for overall spending and the foundational and each foundational area and capability. So now we'll move on to the preliminary results presentation and discussion, where we'll explore an SSA level overview of spending, service delivery, service sharing, and shared staff capacity and expertise. And these are all presented at the shared service arrangement level. And they are going to be included in a full state report that will be available in the fall. And all of that will be anonymized. And there's no information about, or you won't have the names of specific towns in this resort since it's all at the shared service arrangement level. So this slide is just providing some additional context about FPHS and the number of towns that completed this. So you can see that all 6 of the towns in the shared service arrangement submitted complete data for both of the tools that were part of this review. So there was this cost tool and then the service delivery tool, and all 6 towns completed both tools entirely, with large thanks to Megan for all of her amazing support in getting those completed. And reminder that local public health isn't responsible for delivering all these services, and this is not an assessment in any way. So overall, there were 3 grants that were received by members of the shared service arrangement in fiscal year 2024, which all of this data is reflective of FY24. And the total spending across the shared service arrangement in FY24 was $1.03 million, 48% of which was spending from grant dollars, and then $511,000 was spent on community-specific services, which is services that fall outside of the scope of the foundational public health services, which include things like trash or any sort of waste disposal. Anything like that is considered a community-specific service. And regional positions included 5 occupation categories. You can see in this chart on the right-hand side that 5 of the positions across the shared service arrangement were regional staff. So these are folks that are serving more than one community in the shared service arrangement. I'll pause here if anybody wants to chime in and ask any questions about this. So this slide is showing the total amount that was spent on the foundational public health services. So this is the $519,000 that is on FPHS. So the remaining was on those community-specific services. There were 8.8 total staff FTE or full-time equivalencies. And then you can see in the charts on the right-hand side that the highest spending category of the foundational areas and capabilities was in environmental public health, which with 40% of your spending going towards environmental public health. And it was also the largest FTE category, with 37% of staff FTE going to environmental public health, which makes a lot of sense since environmental health covers things like inspections, which is a large role that traditionally local public health is responsible for. So this aligns closely with the rest of the state. So in the service delivery tool, folks were asked to indicate the staff's capacity and expertise for each service under each foundational area and capability. And the shared services staff were also indicated they also were asked to indicate their capacity and expertise. So the shared services staff are those folks that are shared across multiple municipalities in your area. And this table summarizes the highest 2 foundational areas or capabilities for both the shared service staff and the average across the local public health entities in the shared service arrangement. So this table could be used to illustrate how local public health entities and shared services complement each other. So you can see that the highest areas are different for the shared staff versus the local municipal staff, which is showing that you all are complementing one another and not providing duplicative services. Rather, the local staff are providing things like environmental public health really strongly, whereas the shared staff are doing things like communicable disease control, which makes sense since you have shared nurses who are doing that work in your shared service arrangement. So this table is showing essentially the same thing as before, but this first chart shows the capacity and expertise for the shared staff. So we can see the expertise on the bottom and then the capacity on the side, and we can see again that things like equity, community partnership development, and communicable disease are the highest categories for the shared staff in your shared service arrangement. And then this is the chart for the local municipal staff. So averaging the capacity and expertise for all 6 municipalities in this SSA, and seeing that communications and environmental health are much higher on the expertise scale, since these are things that you all are responsible for at the municipal level. And then this last page of charts is showing again the same data, but looking at the local public health staff next to the shared staff capacity and expertise. So the shared staff is shown in the purple squares, and then the local municipal staff is shown in the orange circles. So you can see areas where like in communicable disease control and chronic disease and injury prevention, and then really all of these areas at the top where, except for environmental health, where the shared staff are driving the capacity and expertise, but then other areas like environmental health where the local staff and shared staff are more similar and the expertise is slightly higher for those local staff. And so we can see where you all are complementing one another, and also potentially where shared service staff can be utilized more if perhaps municipalities weren't aware that the shared staff had capacity or expertise in these areas. I'm gonna pause now just again a little bit because the next step is to hone in on 2 of the foundational capabilities or areas. So does anyone have any questions about this capacity and expertise portion of the presentation? I know it's early. I'm going to So we've seen the overall spending, the overall capacity and expertise, and now we're going to spend a little bit of time drilling down on 2 foundational areas and capabilities. So the first is environmental health, and then we'll go over emergency preparedness and response. So for future reference, and since you all have access to these slides after, there's a slide that looks like this for each of the foundational areas and capabilities that provides more information on the SSA level data for each of those foundational areas and capabilities. So environmental health is an important one to focus on since it is most closely linked with the current performance standards. And local public health entities in your shared service arrangement dedicated 33% of your total spending and 37% of staff working hours to environmental public health, which, as I said in the beginning, is the largest spending category and the largest staff working time category. And shared staff are supporting all of the towns in the delivery of the headline responsibilities that fall under environmental health. So these things over here on the left-hand side that say headline responsibility, these are all of the different activities that fall under environmental health in the Foundational Public Health Services framework. So shared staff are supporting folks in all of these, but that doesn't mean that the shared staff are driving these, the delivery of these services. In many cases, it may be that the local staff are really driving these efforts, and then shared staff are just there to kind of provide some support as needed, or they're supporting in certain communities more than others. Almost all of the towns indicated that they were meeting community needs. So over here on the right-hand side of the bottom left figure, we can see them mostly or completely met community needs. So this is showing the number of communities in the shared service arrangement that indicated that their community's needs were being met for this specific headline responsibility. And it's really awesome to note that this bottom one, that the headline responsibility that is asking if you were able to conduct all mandated inspections, 5 out of 6 of the municipalities in the shared service arrangement said that they were able to do this mostly or completely. So this is really showing that you all are delivering these performance standards to the best of your ability, and you're really meeting the needs of your communities in doing these inspections. So that's really wonderful. And then we were able to identify some partners that were helping in some of these things related to environmental health, like implementing programs and strategies and working cooperatively with others whose work impacts environmental health. And then some of those partners that were identified through this process are listed over here on the right-hand side. So things like the Department of Environmental Protection, the Department of Public Health, different fire departments, and legislation, the mosquito control, all of these things were identified as partners who are helping to further your work in environmental public health. And then this center figure here of the capacity and expertise shows, once again, the same average capacity and expertise for the shared staff. And then it breaks apart the capacity and expertise for each of the 6 towns in the shared service arrangement. So we can see that about 2 towns have more limited capacity and expertise, while it looks like 1 town has really comprehensive expertise and moderate capacity. So this can be utilized to see maybe where you could leverage support from the folks in that town where they really have high expertise to potentially support training efforts or things like that for the towns that have lower expertise. Are there any comments or questions about this slide? I know there's a lot going on, so.
I could say that some of the lower expertise are actually from Greenfield, because when I did this survey at the time, we didn't have any inspectors. So don't think that it's just the smaller towns, because some of this is definitely related to Greenfield and not having the inspectors when I did the survey.
Yeah, thank you so much. And that's a really important point, since this is capturing FY24 data. So even now, like if you did this on your current workforce, this would likely look different. And don't be alarmed if you're like, why does it look like we have low capacity and expertise when we just hired this really experienced inspector, or we're training this inspector? This could have changed even since the time of this survey, which is always a flaw in data collection, but important to note where you were in FY24. And then we can already celebrate the changes that you've made since then. So thank you for that context, Megan. So the next foundational capability that we were going to look at, before I say that, for each of these, there's this key summary slide. So if you're looking through this later in your own time, there are 3 to 4 points for each of the data slides that just basically summarize what's on them. So if it's easier to read them in this way. That is also available before each of the data slides. So the next one that we'll look at is emergency preparedness and response. And so for this foundational capability, local public health entities dedicated 2% of total spending and 3% of staff working hours to emergency preparedness and response. And shared staff and outside partners are supporting all 6 of the towns in delivering of the services that fall under emergency preparedness and response. And there are a lot of partners listed because services are spread out across the region. So you can see over here on the right-hand side, a lot of the partners that were listed, things like Bay State Medical, but then also like MAPCO. And then I believe, Megan, you said like FERCOG is involved in some of this work. So it can look different for each of the towns, but all of you have identified some partners who are helping with this emergency preparedness and response work. And community needs were met for more than half of the municipalities, but we can see that 2 municipalities in the shared service arrangement did indicate that their needs were not met in FY24 for emergency preparedness and response. Developing a streamlined response plan that takes into account all of the partners might be a good step to help bridge that gap for those 2 communities who aren't currently having their needs met. And there may be an opportunity to leverage existing capacity and expertise within the shared service arrangement, since it looks like some of the towns in the shared service arrangement do have really high capacity and expertise, while 2 towns, it looks like, have absent capacity and expertise in this area, and 2 have more limited capacity and expertise. So really sharing that knowledge may be able to help better equip those towns with lower capacity and expertise in preparing for emergencies. Is there anything that you want to add here, Megan, or any questions?
I think again, a lot of it had to do with staffing, if you don't have a nurse, if there's if you don't have a regular nurse on staff, your capacity would have been rated low, because in 2024, if there was like a pandemic or something like that, you wouldn't have been able to respond without the shared service.
Yeah, thank you. And also noting that saying you have even absent capacity and expertise doesn't mean that in the event of an emergency, you would just do nothing. It just means that like other things would have to go to the sidelines in order to respond to this emergency. Whereas if you had comprehensive capacity and expertise, it would be just like normal operating procedures in the event of an emergency, since you have that infrastructure to be able to accommodate both. So you're not doing anything wrong if your towns have lower capacity and expertise. And so, as I said, each foundational area and capability has a dedicated data slide and a key takeaways slide, and there's more data available for each foundational area and capability in the appendix, should you want to look at that at a later time. So this is the data to action summary. So this slide summarizes opportunities to further strengthen or improve specific foundational areas or capabilities. So you can see that the first one, these are the 2 headline responsibilities or foundational areas and the associated headline responsibilities that most closely align with performance standards. So those environmental public health ones, and then communicable disease control most closely align with the current performance standards. And then the second category where it says leverage existing high capacity and expertise. So these are areas where some municipalities in your shared service arrangement indicated having really high capacity and expertise, while others indicated having lower capacity and expertise. So these are community partnership development and then policy development and support. So these are areas that perhaps you could work together to leverage that high capacity and expertise from some communities to better train and support those in communities with lower capacity and expertise. And then the 2 areas where there was the lowest capacity and expertise were assessment and surveillance and policy development and support. And some of this also may have been because of limited staffing in FY24 that may have already been addressed, especially for that assessment and surveillance piece. I think hiring more staff generally helps with that foundational capability. So this could have already changed since FY24. And then the area where services really aren't currently being provided is maternal, child, and family health. And this is likely because local public health in Massachusetts hasn't ever really been asked to provide maternal, child, and family health services, but working to identify the partners in your community who are providing those services. So like local nonprofit organizations or community-based organizations, churches, hospitals, things like that, would just help make you aware of which maternal, child, and family health services are available in your community. So should you need to point folks in the direction of those services. Yeah, Megan, do you have anything to say about this slide, or we can? Okay, awesome, thank you. So the next bit, just go through really quickly, is the data to action toolkit. So we've already finished the FPHS data collection. The next step is to use this in planning for your SSA, and then work really on building capacity utilizing the FPHS results. And this toolkit is primarily going to be used by Megan and then any of the directors in the shared service arrangement, but it'll be used to utilize the data to inform decision-making and planning moving forward and providing actionable insights. So there will be 3 resources that will be released when the work plan is released in mid-May. The first is an FPHS work plan crosswalk that shows how FPHS is integrated into the Public Health Excellence Grant work plan. And it shows how SSAs can select work plan activities that align with the identified FPHS areas of opportunity in their communities. And then there is a partner mapping template that supports you with mapping out service providers and partner organizations. So should you want to really map out where all of your emergency preparedness, for example, providers are located, what they offer, the strengths and weaknesses in each of those partners, you can utilize this partner mapping template to help you do that as an SSA. And then finally, there's an FPHS facilitation guide that provides questions by foundational area and capability to help facilitate discussions and solve problems and things as the shared service arrangement. So just kind of to continue this discussion around the foundational public health services. And to help you navigate these resources and also understanding your data, you're welcome to reach out to members of the Office of Local and Regional Health team, Katie, who's on this call, and then Christina, as well as folks on my team at BME Strategies, and then subject matter experts from MHOA are also going to be available to help walk through the data or utilize the 3 tools mentioned before and really help provide an opportunity for you to leverage this data and continue this conversation about FPHS. And that is all of my presentation. I am happy to answer any questions, or if you have any questions that you have for DPH or ORH, we have 2 folks on the call to answer any questions for you as well. So.
Just wanted to say thank you, Kyla, for all your hard work.
Of course, thank you so much. Megan did so much. Yeah, Ileana, go ahead.
Oh, sorry, I was gonna do the clapping hands, but I clicked on the raising hand. Also, yes, thank you both Megan and Kyla. You both are amazing for all the wonderful work you did with this. Thanks.
All right, well, I know it's early in the morning and you have other agenda items to get through, so I will stop talking, but please feel free to reach out via email if you have any questions or if you want to have any more information about the data or anything like that. Yes, and thank you so much, Ryan, for completing the tool as well and all your work on it. Really appreciate it.
No problem.
Okay, so I think it's probably okay to go to the next agenda item. Is that all right with everybody? Okay, perfect. So first, do we have a motion to accept the meeting minutes? I see that there's a couple small spelling changes that Tim wrote in the chat. Is there anything else that anyone had about the meeting minutes?
Yeah, I did. I on the very end, it says that Mary's going to collect the fees if the inspections, and the towns are gonna accept them directly.
Yes, that's correct. Each town will take their own fees and issue their own permits. The only thing that we are going to do is go out and do the inspection, and we'll tell you that we completed it and send you a report.
Correct, but that's not.
We
the
will
way-
fix that. Yes, we will fix that. Okay. Does anybody want to make a motion to accept the meeting minutes from last month? With the changes?
Make a motion that we accept last month's meeting minutes with the drafts that were discussed.
I'll second it, John Leverett.
All in favor?
Aye,
Garrett, I.
John, aye.
Megan, I. Ryan.
It's
All right,
muted.
Ryan, I.
That's okay. Perfect. All in favor, motion carries. Nursing activities. So we did a health fair at Greenfield Community College. They worked with the nursing students there. Robin was there. And did a menstrual equity project as well as gun safety. She did more Narcan training. I believe Anne did Narcan training as well. She came and picked up a bunch of boxes of it. Sarah went to the Nacho convention in San Antonio, or Nacho, and she said that it was wonderful. She had a great time, and she's going to give us a report, I believe, next month and just give us a little summary of some things that she learned. All of the nurses are going to the MAPHN conference next week. Sarah worked really hard on a poster presentation on menstrual equity to share with all of the other public health nurses. So we're all going to do that together at the convention. Cindy's been doing, oh, I'm sorry. Anne has been doing home visits, covering for the senior center and covering for Cindy. Cindy is still out probably for another month, it sounds like. The new inspector, he's really has rolled, I'm sorry, I'm echoing in the other room, it's distracting. Has really been doing great. He finished ICS 100, 200, 700, ServSafe, Tier 1 food courses, Tier 2 Tier 1 housing courses, the FDA food courses, and he has done all of his foundations of local public health. And yesterday was his first day going out and doing food inspections by himself. So he's really coming along quickly. So if you need any of his services, make sure you reach out to Marion and we can share him. He'll be doing his pool inspection course on the 20th or 23rd, something like that. 22nd, 23rd of this month. So, and we have him on the wait list for the Tier 2 housing and food. Relevant. So I met with the relevant people. We were spending about $44,417 without the pool inspections. If we take off the housing inspections and not have the pool, we can bring it down to $23,792. I surveyed all of the other towns and nobody is using the housing. So I think that, I would recommend that next year we don't do the housing in the pool. The pool is $600. Most of us only have 1 or 2 pools and we charge $150 fee for the pool inspection. So we'd be paying quadruple than we bring in for the pool inspections to have that software. So that's why I don't think it's a good idea to have the pool if we have such limited amounts. But I am hoping that we can get rid of the housing if nobody's using it and save almost $20,000. Can we have some thoughts on that?
I'm okay with getting rid of it as long as we're making a consistent effort to ensure that all of our inspectors are going through Tier 2 and Tier 3 housing training.
Oh, yes, absolutely, absolutely.
Because I do think it's important that we have consistent reports, but I think that housing in particular is really well supported by the state right now. I just went through most of Tier 3 housing. I'm just waiting for the field portion that they haven't started yet in our region. And I think it was really helpful because it's, a lot of bringing people to one table and making sure that we all do housing reports the same. And I think with that savings that I would be supportive of getting rid of it, as long as we're sure that we're still meeting the requirements of our IMA.
I 100% agree. Garrett, maybe could you find out if Claudia is doing these trainings?
And it's just specific to the housing inspection.
Housing and food. So we would
Okay,
want her
food.
to also go through the tier 1, tier 2, and tier 3 housing that the DPH is offering. If your town needs any, I think all of these are free, but if anything comes up and she needs funding for it, the SSA can certainly help with that.
And Garrett, I don't know if you have Bree Dupros's contact information, but she's the regional trainer. So that would be the contact for setting up any of those trainings. I can put it in the chat if you don't have it.
I think I have emails from her.
Okay, great. Yeah, so she sends out regular updates that I think Claudia should be receiving.
Sounds good. I will check.
We did the.
Can I
funding.
ask a quick question? How long are these trainings? Because I don't know if Steve has done those.
I don't believe Steve has either, but he's away right now.
They're pretty
So
time consuming, John.
yeah, they are. I would say
Sure.
the online portion is around 40 to 60 hours. Does that sound about right to you?
I think you could probably cruise through it a lot faster than like maybe the stamped times on it, but yeah, it's pretty long. And then as far as the actual in-person, it's several weeks of meetings for the housing one, and the food one's usually done in a similar way. So I think it took me about 6 weeks to go through the tier 2 food course at the end. In the tier 3 housing. But it's not every day, it's like once a week or something like that. It can be spread out. It's probably about a week's worth of classroom time, I would say.
Any other questions on this? Okay. So I put discuss wishes for FY26 budget, and I know Tim had to go, but right now the Deerfield nurse is only budgeted for, this is Cindy, their actual town nurse is only budgeted for 12 hours a week, and they wanted to increase her to 18. So I thought that the SSA could fund that extra instead of hiring another SSA nurse. But Cindy, if we needed her to work in the other towns for any of those times, she could do that. So she's technically SSA staff for 6 hours a week. Right now, she's already covering Sunderland and Deerfield because we have a joint senior center. It would be about $13,000 a year. I already checked with Ileana, and this is something that can be approved. And right now, Deerfield gets the lowest, well, besides Greenfield, who doesn't have any nurse, but Deerfield gets the lowest amount of nursing hours, Deerfield and Sunderland nurse. So this will make it equal to Montague and Leverett Shutesbury. Any discussion on that?
I would make a motion that we fund the additional 6 hours in order to ensure equal coverage across the shared service communities.
Garrett, second.
All in favor? John?
John, I.
Ryan?
I
Garrett?
Garrett, I.
Megan, I. Any other wish lists that you can think of for FY26 that you want me to try to build into the budget?
This isn't necessarily a budget question, but with respect to nursing, do we have any capacity to spend some time on like mosquito and tick outreach in Montague this summer?
Absolutely.
We're still not part of a mosquito control district, and it's not necessarily clear whether or not we will become part of one. So in the meantime, it'd be great if we could do just like in person, maybe tabling or something like that. And I know our nurse also has some capacity, so if they wanted to coordinate with her, maybe she could be involved with it as well. But if not, that's fine too.
Yeah, definitely. And we did purchase a bunch of supplies too, so that, if we could have, maybe Robin and Brittany go to a senior center or the town hall or something like that, do a presentation. And we have bug sprays and things like that they can.
That'd be awesome because we did something like that last year, but we don't have the same funds for the supplies that had been given out. We gave out about $1,000 worth of just different mosquito products.
Yes.
And a good place would be maybe like Unity Park or something where there's a lot of people outside.
Yeah, perfect. Unity Park. Okay. Right, and that was purchased with the COVID funds, not, I know PHE funds don't let us buy that, but COVID funds did.
Oh, no,
Which
when we bought it, we had a mosquito line item for it. I was talking about a Montague's
Oh,
budget.
I thought you meant I thought you meant
No.
the ones that I said, and I was like, in case Ileana's listening, I didn't buy it with PHE money, I bought it with COVID money, we're just sharing.
No, this was appropriated at town meeting.
Perfect. Any other wish lists? No. Okay, so I've been working on the budget for next semester, or next fiscal year. So I will we'll go over that next meeting, I guess. I think time is going by really, really fast. So next meeting is the one that we'll have to vote on that.
I think the only other thing I could think of, Megan, would be is if the nurses can think of something that would help to support work they're doing in the towns. Yeah, I'm just thinking Sarah's so active with Leverett and Shutesbury, particularly around health education stuff. So if there are resources that we can purchase because it's an allowable purchase that support the health education work that they're doing.
Yes. We did, chick spoons we were allowed to buy with PHE money, so we did buy a lot of those. And we are educating people on how to use them. They're not giveaways, right, Ileana? So yes, we are absolutely doing that with anything the nurses are asking for. I'm making it happen in one way or another, whether it's COVID funding, PHE funding, they're getting everything that they're asking for.
Is it possible to get additional staff time to help at least us, and not about other boards? We need to look at some of our regulations, do new regulations, just really spend more time. And it would be very helpful if we had somebody more driving that than us, because we just don't do that.
To John's point, perhaps we could try to find some room in the budget for like consulting when that comes up. I think that a lot of the towns probably could use assistance in drafting new Board of Health regulations. I've spent time doing some of those here, but having full-time staff hours, it still is hard to get to it. So I can only imagine what it's like when you're working with limited staff.
I'm sure that we have that I'm sure we have money that I can do that with, especially if we're saving $20,000 in relevant, we could put that towards a consultant. The trick is going to be to try to find somebody willing to do it. I know we tried to find a consultant, because we had extra money this fiscal year, and we went to what is it called? The person with expertise, and they couldn't find anybody for us. What is the name of that? Well, it's okay.
MHOA might be a good resource. I know they do a
Yeah.
lot of contracting with subject matter experts.
But yeah, that's exactly what I was trying to think of. We met with our subject matter expert and tried to get a consultant for like an inspector position when we were short, and they couldn't find somebody willing to do it. Ileana has something to say. She might have a.
Thanks, Megan, and thank you all for allowing us to be in your meeting. I did want to just announce that we do, and Katie's on the call as well, and she kind of heads this program. We have technical support available for people who are in the PHE program, who are not in the PHE program. Megan mentioned this, that she previously tried to get a subject matter expert for, I can't recall, it's been a while.
It was the inspector. We tried to get somebody to like fill in as a temporary inspector for us, but it didn't happen.
Yeah, but there's definitely technical support services, if regulation review is something you need, or if there's other services. And also in the PHE budget, there is a line item, like Megan was mentioning, for consultant, that you can allocate some money for that. And wonderful Katie just put in that form in the chat. Thanks, Katie, to request that technical support. So I just want to mention that. Thank you.
Thank you.
And for the less staff departments, I'll say that, the technical support's really helpful for getting guidance, but I would say it's maybe a little bit different than like paying for an outcome. So for example, like hiring an inspector or hiring someone to actually draft a regulation is different than maybe having them review a regulation.
Ryan, do we want somebody to actually draft the regulations though, right? That's what we're hoping for?
I don't necessarily need that service maybe as much as some of the other towns, but John, I'm imagining that like it would be more easy for you guys to have somebody completely prepare a proposed regulation that your board can review as opposed to just you guiding. Yeah, okay.
Absolutely.
Yeah.
I mean, we're looking at PFAS and, you know, we've done a bunch of stuff, but nothing's really been, I haven't really seen anything that really works for us. And again, we're a volunteer, so it's difficult.
I think another good example that we've experienced in Shutesbury is around green burial.
Oh, yes.
Yep.
So,
Okay,
and we've spent a lot of our volunteer time on that topic.
yep. Okay, so I will add that into the budget and then we'll try to come up with, we'll meet with the technical support to see if we can get somebody to do those for us, because I think green burial and PFAS are definitely something we need in Greenfield too. We don't have any regulations. We have like a very minimal thing on green burials. We allow them, but unless you've planned really far ahead, there's no way that you can actually do it and get the permission. Perfect. Thank you, Katie.
It might even be worthwhile once we get into the new budget period to all meet and talk about which regulations we need the help with the most, because we might be able to get like a prepared model regulation and then all the towns could look at it.
Yeah, that would be great. I also just wanted to let you know that Mary, she is normally, well, she's been working 30 hours for us. Her contracted time is 19, but with Social Security rules, she's only going to be able to do 10 hours with us until January, and then she'll be able to go back up to about 18. So I will have a little less support, until January.
Sorry to hear that.
But
If
it's
I
okay. My answer for everything is we'll figure it out.
Meg, if I could take something, we were talking about the meetings, and so I pulled up the notes here, and I specifically wrote on here, Leverett and Sunderland inspection is expected to be unavailable until September. When an inspector is needed, please refer to Mary at the Greenfield Health Department, and she will schedule them. As for the fees, each town will collect payment prior to sending them to Mary. Greenfield will not be responsible for collecting fees. Greenfield will only need a week's notice to do the inspection. So I did not write on there that Mary would be collecting fees. So I'm not sure how that was misread.
No, it said that the fees would go would be delivered to Greenfield or whatever it said.
I just read you the thing. So that's why maybe it was the way it was read separately, but I thought it was pretty clear.
Well, I can talk to you later, but I was pretty
Okay.
clear to me.
Okay.
Does anybody have anything else that they wanted to discuss? No? Do we have a, oh, actually the next meeting. So the next meeting, I have June 12th is when it's supposed to be, but I will be at the Tier 2 food training course that day. I was wondering if we could do it the 13th instead at the same time.
Which is the
Oh,
13th.
Ryan says no.
Well, Fridays.
Oh, it's a Friday. Let's see. June. I'm just gonna check Monday, June 9th. Would that work for anyone?
I am not available, but I believe Noreen will be back from vacation by then, so.
Does anybody else have a problem with that date? All right, let's go ahead and schedule it for June 9th, as long as we can get Noreen. I can always change this if anybody emails me and says it's not gonna work, we can figure something else out, but, I don't wanna skip the June meeting just because I have to go over the budget so that I can send it into Ileana on time. Okay, do we have a motion to adjourn?
I make a motion to adjourn, and my request that Mary stay on so I can talk to her.
Sure.
Second,
All in favor, Megan, yes?
Ryan,
John,
yes.
yes?
Garrett, yes.
Okay, bye, everyone.